Good morning. Good morning. Nice to see you all. Welcome to those in the room and welcome to those on Zoom. Happy to have our second in-person grand rounds. And good morning, Dr. Cespedes. Good morning, Dr. Campbell. Good to see you too. Welcome. And so with that, I will turn it over to our chief resident, Dr. Casante, and we'll introduce our speaker.
Thank you, Dr. Thomas. Dr. Matthew Abramson is an academic nephrologist and assistant professor of medicine at the Icahn School of Medicine at Mount Sinai. Born and raised in New York City, he completed his internal medicine residency at Stony Brook Medicine, followed by general nephrology fellowship at Weill Cornell Medicine. There, he developed a passion for onco-nephrology, completing an onco-nephrology subspecialty fellowship at Memorial Sloan Kettering Cancer Center. He was instrumental in founding the Onco-nephrology Clinic at Mount Sinai, and his research interests include understanding and improving kidney outcomes in patients post-stem cell transplant and in patients with multiple myeloma. Please join me in welcoming Dr. Abramson for Grand Rounds.
Thank you, Nicole. Thank you to the division leadership and department leadership for the invitation. I'm so excited to share with you my clinical and research passions, and just give you a kind of a taste of what onconephrology means in the hospital setting and how it intersects with hospital medicine. I have no relevant financial disclosures. So a couple objectives today is one, to recognize onconephrologic emergencies and to identify pitfalls in the management of these emergencies. So this is a typical rounding list that I remember as a resident. The most overwhelming thing you can get in the morning from your night float. 7 patients, all very sick, all admitted to the medicine service. None in the ICU. They're all just waiting. There's initial emergency room evaluations are done, and you're next up. And I would argue that a lot of patients on your list will probably have cancer, active cancer, or maybe being treated for cancer. So the first patient with back pain and night sweats, with no history of cancer, coming in with AKI, anemia, and hypercalcemia. Your second patient, just coming in with some fatigue, weight loss, night sweats with a history of MDS, found to have acute kidney injury. Next patient, very tense abdomen, painful abdomen with history of endometrial cancer, admitted for AKI. Dizziness, patient recently received cisplatin for bladder cancer, AKI, and hyponatremia. And the list goes on. And finally, there was a consult from the oncology service, for, you're not the primary for, but it's a medicine consult for AKI and a patient that received a stem cell transplant. So how do you reconcile all these cases? We'll go through a few of them. We won't have time for all of them. Maybe at a future grand rounds, we can discuss some further ones. But you're getting ready for rounds. You look at the initial workup for everybody that was done in the emergency room. You start calculating your FENAs. FENA less than 1%, great. What do I do next? FENA less than 1%, great. What do I do next? FENA less than 1%, great. What do I do next? Goes on and on and on. So there's a little bit of ambiguity with initial workup for AKI, and I hope we can clarify a few things during this talk. So the outline of this talk will be a general approach to AKI in hospitalized patients, followed by a brief introduction into what is onconephrology. And we'll do the majority of the talk centered around three cases, all of which are onconephrologic emergencies. A patient that has undergone stem cell transplant, a patient that's having tumor lysis syndrome, and finally a patient with light chain cast nephropathy. So acute kidney injury, we all know the KDIGO criteria for AKI, stage 1, 2, and 3. Stage 1 is the least severe, at least 1.5 times their baseline. Stage 2 is between 2 and 3 times their baseline creatinine, and stage 3 is more than 3 times their baseline or needing dialysis. And don't forget about the urine output criteria to further understand a patient's AKI, as the oliguria or anuria may precede the creatinine rise. And I also want to mention, not all acute kidney injury is bad, because AKI criteria can be met by diuresing a volume overloaded patient. This is actually a good sign, meaning your diuresis is probably effective. Receiving a medication that increases creatinine but does not affect GFR, usually by blockage of the tubular secretion of creatinine, and it's actually not affecting their kidney function. Patients that have reduced effective circulatory volume for various reasons. And then you actually have actual damage to the kidneys, damage to the kidney tubules, interstitium, damage to their glomeruli or the renal vasculature. So just some more nomenclature. AKI, usually think of it as a kidney insult occurring from hours to days. Acute kidney dysfunction is an insult that's ongoing from days to weeks, and progressive CKD is usually more than 3 months. So some caveats regarding AKI. I would say to avoid volume overload as much as possible. There's increased mortality in a wide host of patient cohorts. ATN does not recover faster with IV fluids. But the caveat is if a patient is recovering from ATN, to monitor for inappropriate polyuria, which could be a sign of the post-ATN diuresis. If urine studies are pre-renal, just like in a lot of our cases on our rounding list, but the volume status is worsening, take a step back and think about other reasons for the pre-renal urine studies, such as other causes for reduced ECV. I would be cautious with using urine eosinophils to help differentiate between interstitial nephritis and ATN. It's very poor positive predictive value. So again, just to reemphasize, fluid overload is bad. Fluid overload leads to all these problems: bowel wall edema, endothelial dysfunction, stretching of the atria, renal congestion, abdominal pressure increase. So fluid overload causes AKI, and AKI worsens fluid overload. We all know the Michelin person on our services. We try to avoid this as much as possible. Again, fluid overload has a higher propensity for mortality, and vice versa. Maintaining a net even to slightly net negative fluid balance in ICU setting confers to better mortality, both for patients on dialysis or not on dialysis. This is a great quote. Whenever clinicians decide to prescribe IV fluids, they need to weigh the risks and benefits of giving fluid in order to optimize patient outcomes. So this is a concept that I like to call permissive hypercreatinemia. Patients that are truly volume overloaded and will benefit from diuresis despite a creatinine rise. Patients with CHF, CKD, nephrotic syndrome. Oftentimes the creatinines actually may be diluted due to the hypervolemia, and even the rising creatinine may not signify a reduction in GFR, but may just be more of a hemoconcentrating effect. And also medications that are started usually in your cardiology patients or your nephrotic syndrome patients, which reduce intraglomerular pressure, and the whole purpose of it is to slow CKD in the long term, but there is a rising creatinine with these agents. So just to continue the same idea, pre-renal is the hardest acute kidney injury to diagnose and manage because pre-renal can be caused by anything except for mainly tubular interstitial disease. We talked about reduced ECV. Even acute GN can present with pre-renal urine indices. Nephrotic syndrome, capillary leak syndromes, thrombotic microangiopathies, renal artery stenosis or renal artery thrombosis, iodinated contrast, other medications like NSAIDs and calcineurin inhibitors, rebound sodium retention after diuretic administration, and even tumor lysis syndrome can present with pre-renal urine studies. So despite the urine studies, if there's a concern for acute tubular injury or ATN, we advise spinning the urine, and you can always consult nephrology for assistance. This would be a high power field of granular casts. And that would be a signal that there's active tubular damage. If the patient has ATN and is volume up, diuresis may benefit them the most, even if their urine studies are pre-renal. You can do a furosemide stress test to see if they have to estimate their higher chance of recovery and also to help with their volume overload. And recovery for ATN is slow, so it requires patience. Dialysis and diuresis should not delay renal recovery, but just avoid hypotension and other inciting kidney AKI factors. So just to bring home the point, does a FeNA of less than 1% exclude acute tubular injury? We already surmised the answer was no. And you can see in this recent Kidney 360 article that even in a patient with a FeNA of less than 1%, still a third of them, have granular tubular casts, and those patients undergoing kidney biopsy were found to have acute tubular injury on biopsy. Just don't forget about post-renal AKI. It is common, 5 to 10% of all AKIs. Patients over the age of 75 have a very high likelihood of elevated PVRs, and these are associated with UTI, constipation, fecal impaction, immobility, and anticholinergics. And bedside POCUS or just a bedside post-void residual is really important in these patients, especially when they have AKI. Renal bladder ultrasound is always reasonable if you aren't able to perform the bedside POCUS or the result is ambiguous. So renal workup for AKI prior to the renal consult. I always say the first and foremost is your clinical gumption. You know the patient best. You know what medication the patient received. You know how the patient reacted to the medications. Your gut and understanding of the patient is always the most important part of the workup. Urinalysis is always advised in an acute kidney injury, evaluating the urinalysis in the appropriate setting. We talked about bladder ultrasound, renal bladder ultrasound. Urine electrolytes are appropriate, especially in the setting of oliguria. Urine protein studies in the appropriate setting. If you think the patient has glomerulonephritis, they have AKI with some hematuria and proteinuria, you can order some, serologic testing and those type of things. But I think at that point, it's probably time to just get a specialist on board. And I would rarely recommend 24-hour urine collections. So if patient has bright red hematuria with or without clots, usually not glomerulonephritis, you should rule out traumatic Foley, nephrolithiasis, bladder mass, or hemorrhagic cystitis. So when I think of glomerulonephritis, I think of beer, shades of beer, and not Bloody Marys. So urinalysis, I feel like this is the nephrologist's best friend, and it probably should be the internist's best friend as well. Urinalysis gives a lot of information. Protein, so the protein dipstick tests for albumin only. So if a patient has non-albumin protein in the urine, it will come up negative. This is the nephrology cheat code right here. So when you look at specific gravity, it tells you how concentrated the urine is. And when you have a 10-10 specific gravity, that's called isostenuria, meaning that most likely the serum and the urine osmolality is the same, probably indicative that there's some tubular injury, or the patient is on a loop diuretic. And if there's blood on the dipstick, then there's a manual review in the lab to count the red blood cells. Sometimes the urinalysis will report casts and crystals. Those are less reliable. If you start to get a lot of casts and crystals reported on your urinalysis, it's also probably time to spin the urine on your own or ask a nephrologist for assistance. So we're going to move on to the true crux of this talk is what is onco-nephrology? I consider onco-nephrology the bread and butter medicine on steroids with a pinch of chemo. So onco-nephrology is a subspecialty within nephrology with an expertise in kidney disease and cancer patients. It's a collaborative effort with oncologists, acute kidney injury and chronic kidney disease in cancer patients, managing nephrotoxic effects of anti-cancer therapy, managing paraneoplastic renal manifestations, medical management post-nephrectomy, how to manage patients receiving chemotherapy and dialysis, and also patients that are planning for a kidney transplant with history of cancer. And then also pain management, guideline development. Chronic kidney disease patients are very underrepresented in clinical trials. So that's really important as well. So CKD is very prevalent in cancer patients. Depending on the cohort you look at, it can range from 12 to 25% of the populations with an EGFR of less than 60. Acute kidney injury is also pretty ubiquitous in cancer patients. Depending on the study you look at and depending on the cancer, it can be up to 20% incidence per year. And in 5% of patients with acute kidney injury that have underlying cancer, they require dialysis. AKI occurs in critically ill patients with hematologic malignancies uniformly, up to 60% of patients. And at diagnosis, multiple myeloma, bladder cancer, and leukemia have a very high incidence of AKI. Risk factors for AKI, advanced cancer stage, underlying CKD, and underlying diabetes. Mortality increases with each in-hospital AKI stage. Whether you look at the rifle criteria or the more recent KDIGO criteria, their mortality increases as your AKI worsens. So most AKIs fall in like a stage 1 with a creatinine increase of about 1.5 to 2, and then about 21%, which has with a creatinine increase of more than 2 times their baseline and failure of 3 times more their baseline. So it's a pretty widespread severity breakdown, but even 11% of severe AKIs, it's important. AKI usually occurs within the first 2 days of hospitalization, and that's in up to 45% of patients. In patients with AKI, length of stay can be up to 100% longer, cost of stay 106% higher, odds for mortality in patients with AKI 4.7-fold higher. And again, each stage of AKI confers a higher relative risk for mortality when a stage 3 AKI with a relative risk of 2. So again, survival stratified by AKI severity, and you can see that this is a 90-day survival curve, and you can see that in patients that have rifle criteria F, which is 3 times their baseline or needing dialysis, their survival is about 50% by 90 days, compared to no AKI where the survival is around 95%. And of course, ICU patients do worse. Hospital mortality in patients in the ICU with cancer, if they don't have AKI, it's about 13%, but then if they're stage 3 AKI, it's about almost 90%. And overall mortality in the ICU with AKI is 78% in cancer patients versus 68% in non-cancer patients. Finally, AKI confers to worse malignancy outcomes. In patients with hematologic malignancies who develop AKI, they have a significantly lower 6-month remission rate of 39% versus 68%. And a lot of these patients do receive suboptimal chemotherapy because they're not eligible for certain treatments. Back to our rounding list. Let's start at the bottom. So this is a consult for AKI. Patient has AML in remission and has tons and tons of labs, tons of data. How do we sort through this? So a 46-year-old man with hypertension and AML underwent a matched unrelated donor stem cell transplant. Induction, including melphalan, fludarabine, busulfan, irradiation, received GVHD prophylaxis with tacrolimus, mycophenolate, cyclophosphamide, and some antibiotic prophylaxis as well. So in order to understand acute kidney injury in bone marrow transplant patients, we need to understand the anatomy of a transplant note. And this is going to be a brief overview, and it's just enough to get us through these slides. But if you need a more in-depth, and I'm sorry if I don't do this justice to any of the hematologists here, but I'll do my best. So I found this on the Fred Hutch website, and I think this is so true. This was directed for patients, but I think this is actually directed for us too. So every part of a transplant note is extremely important to understand why the patients develop AKI. And if you break it down one by one, you can figure it out. So you look at their underlying diseases, their risk score, their disease status, whether or not they're in remission, their comorbidities, if they had prior treatments for their hematologic malignancies, the type of transplant they received, the date of admission, the conditioning regimen they received, whether it's chemotherapy or radiation, or whether it's myeloablative, reduced intensity, or not ablative, the date of the transplant, and the type of antibiotic prophylaxis they received, and the GVHD prophylaxis they receive. Their engraftment status, whether or not their cells have engrafted, and if they develop GVHD. So, different transplant types, again, this is extremely baseline, basic, but there's 2 different types. There's allogeneic, meaning cells from others, and there's autologous, meaning cells from yourself. So the first type is, your matched unrelated transplant and your match-related donor transplants. Next is your mismatched unrelated, which means it's the worst match, meaning it's a higher risk for general complications. Haploidentical is your best match unless you're an identical twin, meaning that you share an entire haplotype with the donor, as opposed to just the HLA matches. And then you have something called cord blood transplant, which is stem cells from cord blood, which provides a lower risk for your GVHD, but it's much slower to engraft. When you have slower time to engraft, you have increased risk of infection in AKI. And finally, haplocord, which you can combine both a haploidentical stem cell transplant with a cord blood to kind of get the best of both worlds, as haplotype lowers your risk for GVHD, and cord lowers your risk for GVHD. And haplo allows you to engraft a little faster. So maybe a good combination to use both of them. An autologous is cells from yourself, which we're not going to really go into in this discussion, but it is fraught with AKI as well. So stem cell transplants are on the rise. We have about 55,000 per year worldwide, and about 60% autologous and 40% allogeneic. And most of the transplants are matched unrelated donors, with lesser of the other types. And it's easy to conceptualize, but this is the data showing that patients who have HLA matching, they're fully matched, meaning 10 out of 10 HLA. They have the best outcomes over 5 years, and the patients that have less than 10 or less than 9 have the worst outcomes. So what is immune reconstitution or engraftment? That's when your absolute neutrophil count is more than 500 for 3 days. And you can see that the different types of transplants have a different time to engraftment, which I kind of hinted in the previous slide. Normal engraftment for a typical allogeneic stem cell transplant is about 14 to 21 days, excuse me. And if you have a cord blood transplant, it's much slower, about 24 to 42 days. And there's different risks for GVHD depending on the type of transplant they receive as well. So we're gonna move on for transplant type to conditioning regimens. And there's different types of conditioning regimens, and many of them do have renal-related adverse outcomes. Melphalan, for instance, can cause acute tubular injury or acute tubular necrosis. Fludarabine classically causes neurotoxicity and can also cause PRES. Busulfan typically causes lung fibrosis, but can also cause hyperuricemia, hepatic veno-occlusive disease, seizures, and there are some case reports of TMA. And then we can talk about intensity. How intense is the conditioning? Is the conditioning very intense? We would call it myeloablative, meaning it completely ablates all the myeloid cells, and that's a very long pancytopenia compared to non-ablative, which is minimal pancytopenia. And protocol based on intensity, we don't need to look at the specifics, but you can see as it's more ablative, there's more toxicity, there's more protocol toxicity. So moving on to GVHD prophylaxis. The most commonly used drugs include calcineurin inhibitors and lesser commonly with mTOR inhibitors, both of which can cause kidney-related adverse effects. And then the other options listed below cause kidney issues lesser. So cumulative incidence of AKI after allogeneic stem cell transplant, you can see that up to 100 days post-transplant, the incidence of AKI is up to 64%, and severe AKI, which would be stages 2 and 3, is around 30%. So it's rather significant. The etiology of AKI, it depends mainly on the time from stem cell transplant. So early on, you can have something called the Marrow infusion syndrome, where you have like a cytokine release on the day 0 of the infusion, and then you can develop neutropenia, which could increase your risk for sepsis. And then when you start to engraft, days 10 to 14 or a little bit later, you can have an engraftment syndrome, which is another cytokine release syndrome. At that same time, you could also develop something called the sinusoidal obstructive syndrome, which looks like hepatorenal syndrome in a patient after stem cell transplant. And you could develop acute GVHD as well. So from days, before day 0, so after your conditioning all the way through day 100, considered AKI, and then when it's persistent past day 100, it's more of like a CKD, excuse me. And you can develop thrombotic microangiopathy pretty much almost any time throughout your course of treatments. The only thing I wanted to highlight here is, again, increased mortality is seen with increasing severity and early appearance of AKI. And in patients who require dialysis, mortality has been reported in up to 100% of patients, but the case series kind of differ. It kind of ranges from about 60 to 100%. So we're going back to our case, number 1. So this is now patient is day +4 of their stem cell transplant, meaning that they received their transplant 4 days ago, and they have AKI. The creatinine went from 0.6 to 1.4 in 3 days. Patient was given, the FeNO was less than 1%, so the patient received 3 liters of fluids. Patient was also having some diarrhea, no edema, no fevers, and they still don't have engraftment yet. Their absolute neutrophil count was 0. If you look if you do your chart dive, you find that tacrolimus levels are elevated, 26 to 30, with a range of 8 to 12. And the oncology team noticed that, and they held the tacrolimus by the time of consult. So this is toxicity related to calcineurin inhibitors. Calcineurin inhibitors are very commonly used in stem cell transplant and in kidney disease, but they do have a lot of side effects. The first side effect, especially when it's acute, is vasoconstriction, especially when the levels are very high. So renal artery vasoconstriction, and that's why you're getting your prerenal urine indices. They can also cause hypertension. They can cause toxic tubular injury, like a toxic ATN, and they can also cause thrombotic microangiopathy. So, they held the tacrolimus. There were no other major interventions, and the creatinine now, this is day +10, creatinine improved from 1.4 to 0.6. Tacrolimus has started back up, and their levels are appropriate between 8 and 12. However, patient develops AKI number 2. Creatinine went from 0.6 to 1.8, now with a lot of edema, fevers, 5 kilograms of weight gain. Check the FeNO, it's still low. Now finally you see the absolute neutrophil count is going up a little bit. It went from 0 to 200. Not quite engrafted, but it's starting, something is starting. So this is probably a cytokine release syndrome related to engraftment syndrome. The way I like to look at a lot of these renal adverse effects are based on endothelial damage, taking the endothelial viewpoint of the kidney injury or of the multi-organ injury. You can see that endothelial damage is pretty ubiquitous in stem cell transplant patients. Patients with engraftment syndrome, as we mentioned, hepatocellular obstructive syndrome or VOD, graft versus host disease, viral infection, calcineurin inhibitors, radiation can all cause endothelial damage, leading to a kind of a capillary leak syndrome and a thrombotic microangiopathy. So back to engraftment syndrome. It occurs usually peri-engraftment, meaning 3 days before the engraftment to 7 days after the engraftment, so about a 10-day window.
Good morning.
And it usually comes alongside, hypotension, diarrhea, pulmonary edema. It could have pulmonary hemorrhage, and even encephalopathy.
Tesla has been schizophrenic. So yesterday, Sean
treatment of engraftment syndrome, supportive care,
myself,
systemic corticosteroids, and tocilizumab has been used more recently as well.
I'm up in years, and I'll have a
Same
hard
patient.
time with that.
Another
And there's nothing
AKI?
wrong with the car.
Wow. So now the patient actually was discharged from the hospital at day +30.
So-
Finally made it out there.
so
Creatinine
here's my
at discharge was
schedule.
0.8.
I'm in New York.
And it's getting
my
labs
car's
drawn every
garaged one
other
day
day
on
in
Tuesday
the stem cell
on
transplant clinic.
89th Street,
And they found that their
Off-
creatinine had increased
off Madison.
again from 0.8 to 1.8 in the past week.
And then
Again with lower extremity
I
edema,
drive it
hypertension,
to,
drop in platelet count,
drop
in hemoglobin count,
Connecticut. I
a
have a house.
moderately elevated LDH.
uh,
The hematologist did a
Sharon.
schistocyte smear and found there were
and I'm
some.
there.
And
until
again,
Sunday.
FeNO is less than 1%. And tacrolimus levels were
And
normal.
where are you located?
So this is transplant-associated TMA. And this patient had basically all of these findings.
So
So
it would
diagnostic
be
criteria for
best
TMA is pretty much
you
what
would
our
come
patient
to the
has.
garage,
There's different
right?
guidelines, but they all kind of share similar
it's-
parameters.
It's on 89th.
And we talked about how most of
Park
the
and Madison.
injuries
There's
during
two
stem cell
garages
transplant
right next
can lead to endothelial dysfunction,
I'm in
endothelial injury,
GMC.
which can cause alternative complement pathway activation.
It's
So this is a proposed algorithm
level.
for transplant-associated TMA. It's very busy, but I just want to
Now, I
point
have
out a
to
couple
tell
things.
them
First of all,
that you're
rule out
gonna
other
come.
etiologies. Make sure they don't have TTP. Check your ADAMS TS13. Check your coagulation studies. Make sure they don't have
I've done with
DIC.
previous
Direct Coombs to rule out autoimmune hemolytic anemia, and make sure they don't have a viral infection that may have precipitated the TMA.
And if you wanted to do it
And if the patient has
today,
high-risk TMA, if you check their soluble
I
C5b
can
C9 or
reach
their
you.
membrane attack complex in the serum, if that's elevated and they have evidence of end organ damage, then and you rule out TTP, then
Okay.
it's reasonable to start complement blockade like eculizumab. Eculizumab had been studied more
Okay,
routinely
so
in
my
the
car
pediatric
number,
population, but there has been
test for red,
more recently studies in the adult
647.
population.
Please mute
This is a
So I'm gonna,
biased
you're not gonna
retrospective
do
cohort,
it today,
but
right?
you can see that in patients with transplant-associated TMA who received eculizumab, their
What time will you
overall
be here?
survival was 21 weeks compared to 9 weeks. And they have a very good response to eculizumab, 93%. And the patients who received, standard therapy that did not include eculizumab, they had a response rate of 61%. So, the most severe AKI cases, are a smattering of different things. The most commonly, calcineurin inhibitor toxicity, and then ischemic ATN, usually related to sepsis, and then followed by, other nephrotoxic medications like antibiotics, sinusoidal obstructive syndrome, and thrombotic microangiopathy is less.
Okay, so I will call them.
And just the final point about stem cell transplants, weight
Okay.
gain is associated with worse outcomes. So in a patient who has weight gain of more than 20%, which is grade 3, or even grade 2, where they have 10 to 20%, they have a major survivability
very nice about that.
a decrease compared to those who don't have fluid overload. So it's really important to keep these patients on a euvolemic, euvolemic state.
That's perfect.
If you master AKI after stem cell transplant, you master nephrology.
No, not at all.
Nobody's mastered it yet.
Actually, there's 4 new tires
All
on.
So we're going to move on to our next case.
And then
We're going to leave
then I had to put
behind
another
our
one
patient
on.
that got the stem cell transplant is doing
Tires are
very well.
no
They
dents
don't have AKI
on the
anymore.
outside.
We're
so
going
I
to
don't
move
know
to the next patient.
if there's any
And
problem.
this is a patient that actually doesn't have any history of cancer, but is coming in with anemia, hypercalcemia. So a 57-year-old,
right.
she came in with
Thank you
shortness of
very
breath,
much.
lethargy,
I'll call
vomiting,
them right
diarrhea, found to have a creatinine of 20. Initial workup, was concerning in that she had hypercalcemia and anemia
Okay.
as well.
Madison,
so she
and
fulfilled
you
quite a few
my
of the CRAB
telephone
criteria
number,
for multiple
you have a
myeloma.
problem, I'm in the office.
Initial workup by the overnight resident
212,
actually
you have that
was
number,
very helpful
212,
and found that she had very high lambda light chains
1541.
of 15,000 milligrams per liter with a
Should
small
have
M
that.
spike. Immunofixation showed an IgA lambda band, and they did a urine protein to
don't think
creatinine
so.
ratio and a urine albumin to creatinine ratio.
Baller says that
And you can
he's
see that the
charged,
protein level is about 10
and
grams, while the
he'll
albumin is
deliver the
about 1
car
gram. So it's a very
as
large
they get all the
discrepancy of
information.
non-albumin proteinuria.
That's good.
So she has
All right,
most
thank
likely
you
what is a
very
monoclonal
much.
clonal gammopathy, which is an overproduction of monoclonal immunoglobulins in the serum.
Okay, all right,
Or detected in
thanks
the urine.
again. Bye.
And it results from a clonal proliferation of plasma cells or B cells, usually plasma cells. And renal disease can occur due to direct deposition of the monoclonal immunoglobulins, or indirect toxicity of the nephrotoxic immunoglobulins in the various renal compartments. Multiple myeloma is 10% of all hematologic malignancies, usually evolves from an MGUS, which is a pre-malignant state of clonal plasma cell proliferation. Incidence of MGUS, rises as you age. It's over 50, it's about 4% of the population, with 1% per year progression to multiple myeloma. It's more common in blacks compared to whites. And light chain cast nephropathy, which our patient seems to have, is the only accepted renal-related myeloma defining event. So when you suspect light chain cast nephropathy, patient comes in with severe acute kidney injury. You do a urinalysis dipstick without any protein, which means that there's no albumin. But you do a protein to creatinine ratio, and there is protein, usually more than 1 gram, and our patient had 10 grams. And you do the urine microalbumin to creatinine ratio, which is low, and like our patient. And usually the involved serum-free light chains are more than 1,500 milligrams per liter. So the workup for light chain class nephropathy, which the admitting intern overnight had done, was to check an SPEP and a UPEP.
Yeah, this is
SPEP,
Dr.
serum protein
Icahn.
electrophoresis,
Car
UPEP, urine protein
647.
electrophoresis. This is a technique in the lab that separates
somebody from
proteins on
Tesla
agarose
gonna
gel
come
or
around
using light
between
absorbance
11
techniques
and
using a
11:30
densitometer.
to inspect the
And
car.
I consider the
And
SPEP and
he
UPEP as
says you don't have to
quantification
bring
of the
the
abnormal
car up
protein.
if you'll let them go down where it's out.
Immunofixation is a little different in that it applies antibodies
All
to
right.
specific
So,
heavy and
and then
light chain
I'll-
components.
then I'll pick
And I think
the
that's a
car up
qualification to see
round
what
2.
type of protein it is. And then finally, the serum
Okay,
free
thank you
light chain
very
assay
much.
is the
Talk to
quantification of
you.
the
Bye.
unbound kappa and lambda light chains. So this is all, I usually say, you know, especially in a patient coming in with AKI in the hospital and concern for myeloma, I usually check all of these. So mechanisms for AKI with light chain cast nephropathy, essentially light chains and the uromodulin in the renal tubules develop casts, prevents urine outflow, AKI, tubular damage in AKI. Also, there's inflammatory infiltrate due to these casts.
Hello?
So management of
Yeah.
suspected light chain cast nephropathy, this requires an urgent hematology evaluation, usually requires hospitalization.
Oh my God.
Volume expansion is tolerated with a urine output goal of at least 150
I'm
cc's an hour. Avoid loop diuretics as this may precipitate casts.
Okay.
But if they're volume overloaded, it may be necessary. There is some data to suggest that removal of the light chains using Plex or high cutoff dialysis may be helpful. That's a whole other talk. And that's more of a specialized discussion.
Hello?
And then, you can consider giving steroids up front to acutely
Yeah.
reduce the light chain burden while they're awaiting their clone-directed therapies. And and then again, definitive management awaiting oncology.
Hold on. Yeah.
In patients with light chain cast nephropathy, greater than 50% light chain reduction within 21 days is associated with renal recovery. And if you get it within 12 days, it's even a better renal recovery. These are just some beautiful slides. I had to put up one kidney pathology slide. And you can just see in the light microscopy in we call it the H&E stain, just these beautiful fractured light staining casts in all of the tubules involved. And this is classic for light chain cast nephropathy. But to prove yourself, it's not other types of casts. You do a PAS stain, which stains basically for sugar, and they usually stain pale. They don't usually have sugar associated with the casts. And then the trichrome is just a beautiful stain. It's just a lot of scarring. The blue is the scarring, and the pink is the tubule casts. And they're all lambda light chains and no kappa light chains lit up, and that goes along with our diagnosis. So the patient had multiple myeloma on bone marrow biopsy, underwent treatment with basically her light chains reduced close to 0, but unfortunately she remained dialysis dependent. All right, our final case. Patient comes in with fatigue and a history of myelodysplastic syndrome, also has weight loss, night sweats, new skin lesions, fever, and tachycardia. Initially, the patient had essential thrombocytosis, diagnosed like 20 years ago, and then progressed to MDS in 2021, and was started on azacitidine in 2021, and had some response to it. When the patient came to the hospital, they had fever, tachycardia, and a lot of constitutional symptoms, and there was initial concern for sepsis, actually. But this was the patient's labs on a week prior with a white blood cell count of 21,000 with some blasts on the peripheral smear. But on day of hospitalization, the white blood cell count was 80.2, which was a massive increase with 67% blasts. This is a patient in blast crisis. And then the patient received some treatment, hydroxyurea, and the LDH went from 2,000 to 9,000. Uric acid increased from 4.4 to 10. Phosphorus increased from 2.6 to 9.8, and calcium decreased from 8.5 to 7.4. And creatinine increased a little bit from 2.09 to 2.35. Potassium also increased a little bit as well from 4 to 5.6. So this patient has tumor lysis syndrome. And I think we all know what the Cairo-Bishop classification is, but just a reminder, it's how you diagnose tumor lysis syndrome. Requires laboratory evidence and also clinical evidence. Laboratory evidence, usually a uric acid of greater than 8, or a 25% increase from their baseline. Potassium greater than 6, phosphorus greater than 4.6, or calcium less than 7. Again, or an increase of greater than 25% of their baseline. And clinical TLS requires, either end organ damage, acute kidney injury, a cardiac arrhythmia, or seizures. Who are at high risk for TLS? Patients with ALL, AML with a white blood cell count of greater than 50,000. High-risk lymphomas with elevated LDH and bulky tumors, like Burkitt's, diffuse large B-cell, T-cell leukemia lymphomas, and also CLL patients that are undergoing treatment because they have a large volume of cells that may lyse if they're treated. Patients that with CLL, when venetoclax first came out, they were treated with, it was developed for CLL, and there was a small percentage of patients developed tumor lysis syndrome, so there's a black box warning for venetoclax, but pretty much any treatment with CLL can cause tumor lysis syndrome. So treatment of tumor lysis syndrome. One is to maintain the urine output of at least 100 to 150 cc's an hour. If you're not able to maintain that urine output, you can do a forced diuresis with diuretics if needed. And then the second component is to reduce the uric acid. You can use 1 allopurinol or 2 Rasburicase, or a combination. Allopurinol is a xanthine oxidase inhibitor. It takes a few days to achieve effect with a peak effect after 1 week. So if a patient is coming in with TLS, it's less likely to be efficacious right away. And it's best used for prophylaxis. And there's some dosing guidelines, but I just wanted to highlight that in patients that have advanced CKD or AKI, especially if the creatinine clearance is less than 20, it's recommended like a very low dose to start at 200, as opposed to 800 for patients without AKI. Rasburicase works a little differently. Its onset of action is much faster. It's less than 4 hours, and it's a urate oxidase enzyme. So it converts uric acid to a water-soluble allantoin, and it works very well and very fast. The dosing guidelines are here. You can give a dose and repeat it as needed. And I'll go a little bit further into how Rasburicase works and some of the caveats. But again, just to show, uric acid reduction is much faster with Rasburicase than allopurinol. This is over 96 hours. You can see that uric acid drops, from about 6 to close to 0 within 4 hours, while allopurinol, to get from 6 to 2 takes 96 hours. So this is my proposed approach to managing TLS. One is to obtain a G6PD level. I'll go into that in the next slide. The next, again, urine output of at least 100 to 150 cc's an hour. You don't want the urine too acidemic or acidotic or alkalotic, and I'll explain why in another slide. You can give Rasburicase in combination with allopurinol. Labs Q4 hours. And then consider dialysis, and especially get a nephro consult if any of the following arise, or even prior to this from happening. But if it already happens, please consult nephrology if they develop oliguria, intractable fluid overload, persistent hyperkalemia, symptomatic hypocalcemia with hyperphosphatemia, or a very high calcium phosphate product of more than 70. And I usually say the patient should be on a TLS watch until the LDH starts to downtrend. And CRRT may be the best initial approach in patients that need dialysis in this population. Some caveats regarding Rasburicase. G6PD screening is required. If the G6PD level is low, giving Rasburicase can precipitate methemoglobinemia and hemolytic anemia. Because there's a massive amount of hydrogen peroxide that's formed when uric acid is converted to allantoin. Which is a major oxidative stress leading to hemolysis through the reticular endothelial system. And methemoglobin can form, shifting the uroxyhemoglobin dissociation curve leftward, reduced tissue oxygenation. In patients who have methemoglobinemia, usually we use methylene blue as a cure, but in patients with G6PD deficiency, it's actually ineffective. G6PD deficiency is an X-linked disorder, so it's more common in men than women. And populations at higher risk include African, Asian, Middle Eastern, and Mediterranean ancestry. Patients can develop anaphylaxis after repeated doses of Rasburicase. And sometimes Rasburicase has ex vivo activity, meaning that it's still converting uric acid to allantoin in the test tube. So it's recommended to keep the Rasburicase, to keep the uric acid level on ice while it's being transported to the lab. Otherwise, it may be falsely low. Patients that have tumor lysis syndrome, other concerns are something called xanthinuria or xanthine nephropathy. This is actually a byproduct of the allopurinol, and if you give very high doses of allopurinol in a patient with AKI or CKD, they can develop this actually. It's a couple case reports. So just something to think about, and another reason why we dose reduce for patients that have advanced AKI or CKD. Tumor lysis syndrome in solid tumors can occur. Pretty much every solid tumor, it's been reported. It's rare, but it can happen. Spontaneous TLS definitely happens, especially in hematologic malignancies with a high cell turnover. And then if you have AKI in these patients, some other thoughts are, does the patient have hyperviscosity related AKI? Meaning the white blood cell count is so high, causing an increased viscosity, causing arterial compromise and AKI. So let's skip this. Oh, this is actually interesting. So humans are, unfortunately, we don't have the uric acid oxidase enzyme or the uricase, but other mammals do. Most other mammals do. So I guess the question is, can rats and mice develop TLS? I don't think so. But actually, reptiles and birds can. Well, interestingly, birds excrete the uric acid in their feces. Anyways, just interesting. That's a whole other lecture. All right. Do we alkalinize the urine? Short answer is not really. Because if you alkalinize the urine, you may excrete your uric acid more effectively because the pKa of uric acid is 5.5. So if you raise the urine pH higher than that, you should be able to excrete more uric acid. However, pH of calcium phosphate or brushite is 6.7. So if you raise it past 6.7, you may actually develop calcium phosphate deposition. So the sweet spot is somewhere in between of urine pH, and probably around the 6 to 6.5 range to prevent uric acid precipitation and to prevent calcium phosphate precipitation. So our patient received hydroxyurea and IV fluids and maintained the urine output. Also received Rasburicase, and you can see on day 8, LDH started downtrending. Creatinine did go up, but it was a slight delay, compared to day 6, day 8. But on day 20, after outpatient follow-up, creatinine had stabilized at 1.7, and LDH was 816, and the blast count is down to 6%. So this is our rounding list again. We've gotten through the initial workup, the additional workup, and we did we figured out why some of these patients developed AKI, and it was a little more complicated than maybe we had thought initially. And these are just some of the other diagnoses that some of these patients may have, and we can talk about it in another discussion. Like our patient with a tense abdomen with ascites, I call it a pseudohepatorenal syndrome. Patient with cisplatin, AKI, and hyponatremia, renal salt wasting, etc. So where does onco-nephrology fit in the outpatient world? So this is our, I'm happy to kind of talk about our Onco-nephrology Clinic experience. Dr. Priya Deshpande and I, we, alongside our leadership with Dr. He, we started this clinic seeing only cancer patients with kidney disease or kidney sequelae from cancer. It opened in December of 2021. It's in the CAM building on the 4th floor. It's a weekly half-day clinic. It's staffed by the both of us, and we have rotating general and subspecialty nephrology fellows. Our rationale for opening was to expand the subspecialty nephrology care to underserved populations and to improve multidisciplinary team care in this population. How we garnered referrals was we met with oncology clinics to establish relationships and generate a referral base. And we have referrals accepted through email, Epic messaging, Epic consultation. And if you have any patients you want to refer to us, feel free to email us anytime. And these are just some examples of the patients that we see. We've seen in the past year and a half, 25 distinct malignancies. We've seen about 57% liquid tumors and 43% solid tumors. In the patients with liquid tumors, most of them were multiple myeloma, and we do get quite a few MGUS patients as well. The most common reason for referral was AKI, followed by proteinuria, hyperkalemia, TMA, hyponatremia, et cetera. And we do also have a large percentage of patients that have baseline CKD as well, 74%. So at this point, I want to thank everyone for their time. This was a fantastic, wonderful experience. Thank you to the Department of Medicine leadership. Thank you to the fellows. Thank you to the Division of Nephrology, Dr. He, and everyone else in the division. And it was really a pleasure and it was an honor and humbling experience. Thank you.
That's a great discussion. I think it's just great to be sort of cognizant of renal function in all cases, but I think you really highlighted a nice path for evaluation, so thanks for that.
Sure.
In addition to the predisposing characteristics and diseases these patients had, are there any other kinds of characteristics you can tell us about that might predispose to renal complications of cancer treatment other than hypertension, CAD? Are there any other characteristics that you might make us aware of?
So I think some of the issues are, first of all, overestimation of GFR, maybe by creatinine. We still don't have a good answer for that. To measure GFR, it's very laborious. There's been some better data coming out more recently that using this creatinine cystatin C formula may be a better estimate of kidney function. Your 24-hour creatinine clearance, I don't think is that helpful, with a caveat that it is used for dosing certain chemotherapies. And doing a measured GFR, it is done in certain centers, more of in a research manner, and that would be something we could possibly do as a research quality, kind of like a quality improvement study. Another thing that is really important is to check if the patient has baseline proteinuria, or because a lot of these patients with hematologic malignancies have probably underlying glomerular disorders that are underdiagnosed. And if we pick them up early, it may not prevent them from going on the transplant, but it may just give us a better idea of their risks of developing AKI, risks of dialysis.
How do you do that, though, if the dipstick only measures out?
Yeah, in discussion with a lot of the hematologists, there's been more of a move to check a urine protein to creatinine ratio. So that's what we usually recommend. And it should probably be a standard, I would think, going forward, especially patients undergoing stem cell transplant. Sure.
Hey, Matt, thanks. That was a terrific talk. But most of the patients you focused on were patients who were early in their cancer diagnosis or mid-course. What about in your field of nephrology, about patients at the latest stage of cancer? Very advanced, maybe they're already on dialysis, they have advanced cancer, they're near the end. Does it incorporate goals of care and management of dialysis near the end of it?
Yeah. I think absolutely palliative care is an extremely important aspect of onco-nephrology. A lot of these patients, they have many sequelae from their cancer treatments, or if they have metastatic disease from the cancer itself. Some of them are very malnourished. So it's really important to have the discussions to kind of see if the patient would benefit from dialysis, to see if the patient would even survive on dialysis, and to be honest with the patient. That being said, as oncology treatment advances, patients have a lot more hope these days. Even with metastatic disease, immunotherapies, targeted therapies really have extended the life of these patients. Anecdotally, even if the studies don't show it, some oncologists say patients with metastatic cancer can, certain cancers live up to 10, 20 years with their diagnosis. So if you think that supporting them with dialysis to get them to their treatments is reasonable in a lot of cases, even with advanced metastatic diseases. Dr. Chang.
So in my little kidney work that you talked about, SMAC transfusion, pre-Viking, where does like a spot
Yeah, so the guidelines for oncology is usually to check 24-hour urine protein electrophoresis. I think from the kidney's perspective, we get enough data just from the spot, because you're basically just normalizing everything by the urine creatinine, and it gives you almost an estimate of what that 24-hour would look like. And the percentage, of urinary albumin to urinary monoclonal protein, that is really helpful to kind of better understand like what the underlying cause of the kidney injury is. If it's pure monoclonal proteins or pure light chains, it's probably a light chain cast nephropathy. If it's a mix of things, it could be a different MGRS. And if it's pure albumin, you could think of it's like an amyloid. It's kind of how I go with looking at a spot UPEP.
Could you share with us a little bit about your vision for the future onco-nephrology clinic?
Yeah. Well, I think clinically we want to expand our onco-nephrology clinic. We want to have more of the oncologists kind of just at least aware of our clinic, and to increase our referral base. And we want to use the patients that we see in clinic, not just clinical, but we want to be able to expand the research on those patients to kind of better understand, like Dr. Kress mentioned, like why some of the patients are at higher risk for kidney complications. Potentially setting up a biobank, and doing other studies that can eventually lead to either clinical trials or other quality improvement initiatives. And we also do have there's a subspecialty fellow in our division that is helping with us in our pursuit, but we want to make that more formalized as a fellowship here.
I think this was a great review, of what you do with all the house staff here, and a great forum to show your great work, and also to have a good review of AKI earlier in the year for our residents. So great review. So let's thank Dr. Abrams for a great job.
Thank you so much.